and ask Professor Mark O'Neill from Guy's and St Thomas's in London to give us some guidance on how we should measure success. Thank you very much.
Thank you very much, Chris, and to the organisers. It's a real honour for me to come and present at a surgical meeting. It's a day of firsts for me. My first presentation at a surgical meeting, my first trip to Scotland, the first time I've seen a cardiac surgeon show a carto map, the first time I've tried haggis, the last time I've tried haggis for breakfast. So, how should we measure outcomes after AF ablation? This is how I'm going to address this topic. I'm an electrophysiologist, so just to put that out there as a disclaimer first. There are challenges to defining outcomes, and I think some of the reasons why we need randomized controlled trials is not even so much because they're randomized, but because they're controlled. Everybody defines outcomes differently. I'm going to look at arrhythmia-defined outcomes, but arrhythmia-defined outcomes for a doctor are not necessarily of any interest to a patient. So it's important that we look at patient-relevant outcomes. I'm going to mention a little bit about complications. It would be facile to suggest that atrial fibrillation is a single condition with a single mechanism. Atrial fibrillation is a spectrum of disease, from patients who have no symptoms whatsoever, you may have atrial fibrillation and you just don't know it yet, up to patients with long-standing persistent atrial fibrillation who have been through the panoply of cardioversions, drugs, interventional procedures. It has a labyrinthine pathophysiological basis, both electrically, structurally, mechanically. Here on the left, multiple influences affecting the initiation, perpetuation, and response to treatment of atrial fibrillation. And on the right, a more simplified schematic of how we see atrial fibrillation, the consensus document, with multiple mechanisms, including epicardial ganglionic plexi, small wavelets, large wavelets or rotors, focal triggers confined to the pulmonary veins and outside the pulmonary veins, and a mishmash of all that together in one patient. How do you pick out in one patient what's at work and try and target that? We've already heard many times that there are many, many strategies and many, many tools for catheter ablation or for surgical ablation of atrial fibrillation. How do you decide on the right one for the right patient to get the best result? What do we mean by outcome? Well, an outcome is the way a thing turns out, its consequence. This is from the web page of the Cabana trial, a randomized controlled trial of catheter ablation versus conventional therapy for management of atrial fibrillation in patients at high risk, meaning one conventional risk factor or age above 65. And the outcomes in those studies, look at what they are. Mortality, stroke, bleeding, cardiac arrest, cardiovascular hospitalization, heart failure, death. And look where freedom from recurrent AF comes in, way down the list of relevant outcomes. Medical costs, quality of life, left atrial size. All of the trials that you are reading about and looking at are using as their outcome measure freedom from recurrent atrial fibrillation. And in the consensus document, freedom from recurrent atrial fibrillation means freedom from more than 30 seconds of recurrent atrial fibrillation at any stage during the follow-up. So when we talk about success and failure, success is a state of mind, not a state of arrhythmia recurrence. When we're talking about 30 seconds of AF in a patient 5 years after they had a procedure done. So outcomes are affected by many things, and I tried to class them into two broad groups: the patient-determined factors, and really this is probably one of the most important ones for the underlying disease process. The patient population is very varied. A patient with 3 episodes of paroxysmal atrial fibrillation in a year is not the same as a patient with long-standing persistent atrial fibrillation, hypertension, mitral valve disease. Age is important. Other cardiac disease is important. Obesity, sleep apnea, things that we're only now starting to find out about how they influence and interplay with the natural history of atrial fibrillation. And then perhaps the things that you and I are a little bit more interested in from a technical point of view, the procedure-determined factors that affect outcome. Differences in strategies and lesion sets, differences in endpoints and how we define them, the use or not use of blanking periods, the intensity, duration, and nature of follow-up. When do you define cure? Do you define cure at a year, 5 years, 10 years, 20 years? What if they're free of AF at 10 years and have a stroke related to AF at 12 years? Is that a success? Frequency and nature of redo procedures, the variability in accounting for asymptomatic atrial fibrillation, and that will depend entirely on the monitoring that you use. And then incomplete accounting for complications. So really, what are needed are accurate outcomes And for accurate outcomes, we need detailed inputs. So uniform definition of types of atrial fibrillation. I'm sure if I asked everybody in this room to define what they understand by the term persistent atrial fibrillation, we would not get one answer. Meticulous characterization of the patient subgroups on which you are proposing to offer the treatment. Definitions of complications. Definitions which are common across the board to all people working in all laboratories all around the world. The duration of the blanking period. Recommendations for monitoring. How long should we monitor for? How long should we wait before we do a repeat procedure? What is a major complication? Because that is important. What is a device-related complication? So really the whole field of trying to define outcomes in catheter ablation or surgical ablation of atrial fibrillation is a little bit like cat herding. So let's try and put a little bit of perspective on it. Let's look at arrhythmia-defined outcomes. What do the studies tell us? Well, this is from the European Heart Rhythm Association document published in 2010 in the European Heart Journal. And really, these aren't new to you. This is looking at the randomized clinical trials of catheter ablation versus antiarrhythmic drugs, but bear in mind that inclusion criterion in all of these trials is failure of antiarrhythmic drugs, so it's a slightly unfair comparison. And catheter ablation always comes out better. Looking at AF freedom at 1 year, which may be completely irrelevant as an endpoint, for discussion of long-term effective catheter ablation. Catheter ablation always comes out somewhere between 50 and 75, 80%. And so that group recommends that patients who remain symptomatic despite optimal medical therapy, including rate and rhythm control, should be considered for catheter ablation, bearing in mind these features here in making that decision. So the studies would tell us that catheter ablation is better than drugs, and we've seen many, many studies come out with these types of curves, and you can, no prizes for guessing without being able to read from the back of the room which one is catheter ablation and which one is drug treatment. It's always the catheter ablation one that's the better one than the drugs. Professor Cox pointed out these data, and these are key data. These are data from Karl-Heinz Cook's lab, looking at just paroxysmal atrial fibrillation, single procedure success, but remember how success was defined, a single episode lasting longer than 30 seconds at any time during follow-up in 5 years. So single procedure, complete freedom from atrial fibrillation in 5 years, only 46.6%. Fairly miserable from a group that are really, really good group at doing this and in following up their patients meticulously. And with multiple procedures, getting up closer to 80%. What I wanted to point out to you was that they also defined clinical improvement. And clinical improvement to them meant more than a 90% reduction of symptomatic atrial arrhythmia. And this was achieved in 92.5% of patients. And I'm not saying that this is an argument in favor of catheter ablation. What I'm saying is maybe think a little bit about how we define outcome following a procedure. From the same group, and I've chosen to show this slide because it's exactly the same ablation strategy, it's exactly the same follow-up, so it's completely uniform. But this time, looking at patients with long-standing persistent atrial fibrillation. And we probably all have a slightly different idea of what that means. But that means atrial fibrillation uninterrupted, lasting more than 1 year. And you can see that with a single procedure, you shouldn't really use the word success to describe something that's 20%. You should use a different word. Multiple procedures achieving 45% complete freedom from atrial fibrillation. So clearly, these are two different problems, paroxysmal and non-paroxysmal atrial fibrillation, or perhaps mechanism-defined trigger-dependent atrial fibrillation and less trigger-dependent atrial fibrillation. If we look at very long-term outcomes, and this is a paper from Steinberg, which is in Heart Rhythm in press at the moment, will be published within the next couple of months, looking at 445 patients with freedom from AF for a year. So to get into this study, you had to actually be completely free of AF for a year after your intervention. 88% of these patients had only a single procedure, pulmonary vein isolation, and the patients who required more than one procedure were treated uniformly with a roof line, mitral line, and ablation within the coronary sinus. And from 1 year out from their procedure, this is the start, 1 year out, you can see that over time, actually the success rates in these patients, meaning freedom from recurrent atrial fibrillation, is really excellent. You're looking at 80% out of 10 years post the catheter ablation procedure. Things that predicted their occurrence and maybe that might color your decision-making in choosing to go forward with a patient for an AF ablation procedure, or the intensity or duration of your follow-up, the presence of other risk factors. If you had one risk factor, meaning persistent atrial fibrillation or hypertension, then you had a almost 40% risk of AF recurrence. If you had two, you had almost 70% risk of recurrence. So don't just think of this as an arrhythmia. This is a disease process which is different in every single patient. The point has been made earlier, and I don't need to labor it, that the harder you look for atrial fibrillation, the more atrial fibrillation you will find. And much of this literature comes from the mid-2000s, at the sort of dawn of high-volume catheter ablation procedures, where it became clear that doing an ECG every 3 months and a 24-hour tape once a year was irrelevant in terms of defining freedom from atrial fibrillation. As you look harder, you find more, and you find more asymptomatic atrial fibrillation. So incidence of asymptomatic atrial fibrillation during follow-up increases, and symptomatic atrial fibrillation decreases. And this has been borne out on more than one study. So how should we control for that? Well, you might think that the best way to do that would be to implant a device that allows you to monitor patients all the time after a catheter ablation procedure. And that has been done, but it's very difficult to do these kinds of studies, only 50 patients. And they had an implantable monitor put in 3 months before their procedure and followed for 18 months after their ablation procedure, encouraged to keep a diary. Procedural success defined by Verma et al. Was lack of any episode of more than 2 minutes of atrial fibrillation during the monitoring period. That is different to the consensus statement definition. What did symptoms mean? So a symptomatic recurrence, and this is quite complex, but worth pointing out that these are the reasons why, personally, I think that randomized controlled trials are very important for answering these questions. Symptomatic AF meant an episode documented on the implantable loop recorder for which symptoms were documented within 30 minutes before or after the end of the patient-activated recording. That is symptomatic atrial fibrillation. And symptomatic days were any days with arrhythmia lasting 5 minutes or longer, and with diary symptoms lasting 5 minutes or longer. And an asymptomatic day, a variation of that. And what did this study show? Well, what it showed was that before ablation, the mean arrhythmia burden was 2 hours per day per patient, and that was significantly decreased by a catheter ablation procedure. Here you can see a large decrease in stored episodes and ATAF counter episodes on the implantable loop recorder. But importantly, the asymptomatic episodes of atrial fibrillation increased after the ablation in comparison to what was there before the ablation. So really important to bear that in mind. This is a paper that was published about 2 years ago on a large number of patients who underwent catheter ablation, 613, only 17% of whom had persistent atrial fibrillation, but with a very extensive ablation lesion strategy, and not what would be widely done for paroxysmal atrial fibrillation, meaning a circumferential pulmonary vein isolation, so both sets of veins encircled, a roof line, and a mitral line in all patients. And that is a very aggressive approach to paroxysmal atrial fibrillation by catheter ablation. And a cavo-tricuspid isthmus line in the right atrium was done in 173 patients. All of those patients were implanted with a loop recorder and followed for 12 months. And freedom from AF was defined as less than 0.5% of the time per month. And that equates to about 3.6 hours of AF per month. And the patients divided into responders and non-responders. And on the top here, you can see this is time in months, and this is ATAC-AF episodes in hours per day recorded by the implantable loop device. And you can see this is just a big black space. So this is a responder, a patient with no episodes of AF or ATAC after their ablation. And this is clearly very different. This is a patient who is a non-responder. Now suppose you see this guy here and do his 24-hour tape there. He's going to be a responder, isn't he? He's going to be a successful outcome, but you've got it all wrong. Another important finding in this study was that really the burden of atrial fibrillation shortly after the procedure was predictive of what would go on longer after the procedure. So here, less than 0.5%, up to 5% AF burden during the blanking period, so that 3-month period after the ablation, was predictive of the best outcomes. And anything more than that was predictive of a much poorer outcome. So perhaps we should be getting a little bit more sophisticated in how we measure our outcomes acutely and think about how potentially we ask our surgical colleagues to intervene sooner, or should we offer a catheter ablation procedure sooner. But do patients care about any of that? Well, unless they're getting palpitations with it or breathlessness, probably not. Patients really care about death, stroke, hospitalizations, quality of life, and perhaps not so much about left ventricular function, but about its consequences. Cardiovascular hospitalizations for atrial fibrillation are increasing. This is data from Australia, but they're increasing faster than cardiovascular hospitalizations for any other cardiovascular indication. A 203% increase in AF hospitalization. We've heard that an acute episode of atrial fibrillation this morning is a bad thing to get, and it certainly is a bad thing to get. These are data from London, Ontario, looking at 12,000 unselected patients attending an A&E department. There was a 3.3% incidence of death within 30 days of that attendance at an A&E department, where the reason for attendance at the A&E department was atrial fibrillation. Does catheter ablation affect quality of life? Yes, it does. I think there are good data to support a positive impact of, by catheter ablation, I mean any ablation technology to improve quality of life, which is sustained out to a year of follow-up. And these are data published by Dwight Reynolds in 2010. The strong predictors of improved quality of life, interestingly, were having undergone an ablation and freedom from recurrent arrhythmia. If you take a group of patients who are naive to ablation and naive to antiarrhythmic drugs and do a prospective randomized controlled trial, you'd have thought, based on all of the non-prospective data and the randomized controlled trials of patients who were on drugs that failed, that catheter ablation would come out better. This is the MANTRA PAF study. It's a prospective trial of patients naive to drugs, naive to ablation, who underwent ablation or drug therapy, and compared them. The outcomes were no different at 12 months. The burden of AF was lower at follow-up in both groups. There were no differences in cumulative or snapshot AF burden, and this is data presented, this is a New England paper, in a very unusual way for an electrophysiology paper, where the actual burden of symptoms, the raw data, are presented. What did differ between groups at 12 months was that the quality of life was better in both groups at baseline, but with ablation, physical well-being was better than it was for drug therapy. So the bottom line of that paper, the study showed no significant difference between the two treatment strategies and the cumulative burden of AF over a period of 2 years. So maybe cumulative burden of AF is not how we should be measuring our outcomes. I think really the important question here is AF ablation capable of offering us something more than just reduced incidence of arrhythmia? And these are not prospective data, but they are tantalizing data from the Intermountain Group in Utah, published in 2011, and I'll show you another paper published by them also, looking at 4,212 consecutive AF ablation patients who were then age and gender matched in a 1-to-4 fashion with almost 17,000 control patients with atrial fibrillation and the same number of patients without atrial fibrillation. So this is a comparison of ablation versus AF versus no AF, so normal people. All of these patients, a huge number, followed for 3 years. And what did the study show? Well, let's just take total mortality here in the top left, at 1 year in white and at 3 years in black. Here are the patients with no AF. Total mortality, 5%. At 3 years, about 8%. Here are the AF patients. As we heard this morning, AF is a bad thing. The mortality is greater. AF ablation, the mortality in patients with AF who underwent an ablation procedure, and these were catheter ablation procedures, the mortality is similar to patients who haven't got atrial fibrillation. And the same can be shown for heart failure, cerebrovascular events, senile dementia, Alzheimer's dementia, vascular dementia. Now, can you trust these data to say that everybody who's got atrial fibrillation should have a catheter ablation? No. But what it does pose is the possibility that there may be something more to gain by means of an ablation procedure, either catheter or surgical, than just freedom from symptoms. And here are the Kaplan-Meier curves showing that with AF ablation, you are at the same sort of cumulative survival as a patient who doesn't have atrial fibrillation, as opposed to the patient who has AF and doesn't have an ablation. Is that benefit due to lowering the AF burden and remodeling of atrial myopathy post-ablation? Is it because healthier patients are selected for ablation than patients who are refused ablation? Well, that question has been looked at by the same group in a paper published only last year. They showed that AF ablation patients have a lower incidence of stroke than patients with AF who have not undergone ablation, and you've just seen us present that. But the effect spans all age groups. It's independent of the CHADS-2 score, and those are really important data. Here you can see patients with a CHADS-2 score of 0 to 1 who have an AF ablation, AF or F. Here are the ones who don't have AF, in blue. And here are the ones who have AF but don't have an ablation, in green. And that relationship holds true in exactly the same way for increasing cardiovascular risk scores. Perhaps also intriguingly is the fact that the same group showed that the longer you delay from the time of your diagnosis of atrial fibrillation to the intervention that you offer for atrial fibrillation, then the more adverse your long-term outcome. This is looking at AF-free survival in patients who have waited 3 different durations for their procedure, between 30 and 180 days, between 181 and 545 days, and between 546 and 1,800 days. With increasing time to treatment, patients get older. There's more hypertension and longer periods of untreated hypertension. There's an increased 1-year recurrence. There is no 1-year stroke difference in these groups, but death and heart failure are highest in the groups who have delayed the longest. The authors concluded that this was principally because of the risk of developing other disease and the decreased potential benefit of therapy over the same time. Patients are interested in complications when we talk to them about whether they should or shouldn't have an ablation done, or whether it's a good idea or a bad idea. And they ask me, how safe is a catheter ablation? And a catheter ablation is inherently a dangerous thing, just like an operation on your heart is inherently a dangerous thing, but dangerous things can be done safely. Complications do occur. Complications are probably underreported. The complication rate with a catheter ablation of a significant complication varies from somewhere between 2% and 6%. And you name it, you can do it with a catheter inside the chest, delivering energy to the heart. Fortunately, death is very rare with a catheter ablation procedure. This was published in JACC by Ricardo Cappato in 2009, a very large number of procedures, looking at 45,115 procedures, 32 deaths. So death is a very, very low risk complication with a catheter ablation procedure. Can you tell a patient sitting in front of you what the likelihood of an adverse outcome following their procedure is going to be? Well, you can give them some indication. These are data from Taiwan, published again in JACC in 2011. It's no surprise that the higher the CHAD score and the higher the CHADS2 VASC score, the greater the likelihood of an adverse outcome longer after the procedure. And these were 565 patients followed up for over 3 years, looking at 2 important endpoints, thromboembolic events and death. So these scoring systems can help you inform that discussion with a patient about what their outcome is likely to be. So really, just to try to tie all that together, for outcomes, I like to think of rhythm-related outcomes, which are what we are generally very interested in. And rhythm-related outcomes really should be defined as freedom from atrial fibrillation, atrial flutter, or atrial tachycardia off antiarrhythmic therapy. And that should be the minimal effectiveness endpoint of AF ablation. That is shown for every AF trial, whether it is catheter ablation or surgery. Single procedure outcomes should be reported in all trials of intervention, and I think that is the way we're moving. Importantly, consistent monitoring techniques should be employed, because otherwise we're not comparing like with like. And we should consider reporting AF burden and time point referenced AF recurrence at 6 months, a year, 5 years. From the patient perspective, we should be looking at quality of life, AF hospitalizations, because patients are interested in knowing how many times they're going to go into hospital, more or less, because of a procedure. Stroke, significant bleeding, and mortality. A last word about the minimal monitoring requirements. These are from the consensus statement published in 2012 in Heart Rhythm. For paroxysmal atrial fibrillation, at least a 12-lead ECG at every follow-up visit, a 24-hour Holter at the end of the follow-up period, and event recording regularly at the time of symptoms from 4 through to 12 months if that is the follow-up period. The paper recommends at least 2 years of follow-up for all patients who have undergone an interventional procedure for atrial fibrillation, because you cannot say that somebody is cured until you're looking retrospectively. You can't say it prospectively. For persistent or long-standing persistent atrial fibrillation, at least an ECG, and it's probably more useful in this group because if they have a recurrence, they're likely to have a recurrence of persistent atrial fibrillation or atrial tachycardia, and less likely to recur as paroxysmal atrial fibrillation. They should have a 24-hour Holter every 6 months, and in the same way as for paroxysmal patients, symptom-driven event monitoring. And these are minimal, absolute minimal requirements for follow-up. You also need to be able to read an ECG. And this is very interesting. This is a patient who was referred to my clinic last week for a catheter ablation for atrial fibrillation. This was a photograph taken of the ECG in clinic, because I couldn't scan it in clinic, and written up there you can see atrial flutter. Now you look at that and you go, well, it's definitely not atrial flutter. But I can see how somebody might have called it atrial flutter, because you look over here, this looks a bit fluttery. But this is a regular rhythm. This is sinus rhythm. There's a P wave, QRS, PQRS, 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 PQRS. This is sinus rhythm in somebody who's not sitting still in the A&E department. So really important that the means by which we define our outcomes or of very high quality. A last word. I think that where we are, we're at a very exciting time for management of atrial fibrillation, both surgically and by interventional techniques, at the point where perhaps hybrid approach is a very interesting way to go, and it's also very exciting to hear surgeons talking about electrophysiological endpoints for procedures both surgically and more recently. But we do need to move forward, and it's not enough to say that time will change everything, because that's what people say. It's not true. It's doing things changes things. Not doing things leaves things exactly as they are. And that's why I think it really is key, and I would respectfully disagree. I think it's very important that we have a prospective randomized controlled trial of catheter ablation versus surgery in the patient group where we stand most to gain, which is the patient with long-standing persistent atrial fibrillation. Who was it said that? The person I aspire to be, Dr. Gregory House, and that's how he manages atrial fibrillation. Thank you very much.
Thank you very much, Mark. If you don't mind, we'll have the last speaker and then we'll have a panel discussion at the end, because we have to finish at 12 on the dot.